In every patient encounter, I spend the time that's needed to help build the trust that's an essential part of my relationship with patients, engaging their family as well in helping to make sometimes difficult decisions about care. My name is Bruce Feldman. I'm a clinical cardiologist at Lehigh Valley Health Network. My time off is spent in part in study, but also I enjoy biking and running. I'm attempting to swim, so I compete in triathlons with the emphasis on trying. As part of my exercise training for these events and maintaining good physical conditioning, I've learned that it allows me to maintain good health, mental health, and give me good perspective about what it means when a person says to me, I can't do what I did before. It's important that my patients know that I am willing to spend the time that's needed to help build their trust, provide proper communication so that they understand their problem, their options for care, and guide them through a complex process of care. Hello, and welcome. It's a privilege to share with you some of my thoughts about the value of paramedics, community paramedics in our community to help us manage patients with chronic heart failure. I want to thank Orlando Rivera and Chris Greb for coordinating this program. I think it's an excellent educational program for our paramedics, and it'll help you understand our clinical trial to test a hypothesis that paramedics in our community can reduce readmissions to the hospital, a costly process that continues to be a serious problem. To help you understand the background of how we got to this point, I want to share with you some important information about the nature of heart failure and the role of the paramedic in this process. Just as a quick brief overview, which we'll hear many more details about, as you may know, heart failure is a syndrome. It's characterized by reduced activity tolerance. Patients suffer from shortness of breath. They tend to retain water and have swelling. They may have episodes of shortness of breath at rest, sometimes awakening them from sleep. And these episodes can be severe and prompt urgent calls for help, hospitalizations, and the cost and time of that hospitalization to help them with this process. Even with our best medical care and our current processes of care, patients with this syndrome continue to suffer, and they have high readmissions to the hospital, and the disease process eventuates in their death in a high percentage of patients. One of the main problems that we've had is patients having to be readmitted to the hospital soon after discharge. In 1995, this problem was identified based on a multidisciplinary review of elderly patients who had been admitted to the hospital with heart failure. And based on a review of publications, anywhere from 30 to 50% of patients were readmitted within the first 3 to 6 months after their discharge, reflecting the serious nature of the clinical problem. There were many efforts created by physicians and scientists to try to reduce these high readmission rates. But despite those efforts, CMS reported that within 30 days, between 2011 and 2014, approximately 1 in 5 patients, 20% or so of patients, were still being readmitted to the hospital. In our own program, among 1,700 patients who had been discharged from the hospital with heart failure, within 30 days, 25% had been readmitted between the years of 2012 and 2015. I'd like you to think about that number, 25%. That's 1 in 4 patients. It reflects the serious nature of the problem. The most recent assessment of our readmission rates indicates that we still have a serious problem, with about 1 in 4, 1 in 5 patients still being readmitted to the hospital. Most of these readmissions happen within the first week or 2, suggesting that either we haven't offered appropriate care and we prematurely discharge patients, or perhaps the disease process is progressing despite our treatment, or possibly there are other factors at play that govern that process of readmission, either a patient's perception or their family's perception that something is wrong, requiring they re-present to our emergency room and hospital for additional care. If we ask the question, what is it that triggers these readmissions? It's interesting to learn that only 1 in every 3 of the readmissions is actually due to worsening heart failure. 2 out of every 3 is due to other issues that are non-heart related. This is a phenomenon that's been observed in patients with lung disease, after being admitted for infections of the lung, gastrointestinal problems. There's high readmission rates in all these populations of patients, and most of them, interestingly enough, occur because of problems that are not related to the previous admission. And again, it raises the question, did doctors miss the diagnosis? Did doctors fail to treat the underlying disease process or associated problems that the patient has? Or are other issues at play that are governing these readmissions? There have been many efforts to try to understand why people are readmitted within this 30-day window. Some of the variables that have been identified include age. Elderly people tend to be more likely to be readmitted. Comorbidities, including diabetes, chronic kidney disease, chronic obstructive pulmonary disease, peripheral vascular disease, laboratory abnormalities, including anemia, all have been associated with increased likelihood of readmission. Interestingly, just simply the length of stay of the original hospitalization is associated with readmission rates. The longer they're in the hospital, the more likely they are to be readmitted within 30 days. It gives rise to the impression that the comorbidities are perhaps important variables that govern or drive these readmission rates. This allows us to focus on what have been called preventable readmissions. What are the factors that we could address and identify and respond to in a timely way to minimize readmissions? Well, one of them is simply noncompliance with medications. The patients either don't get the medications for one reason or another, or perhaps they don't take the medicines even though they've purchased the medications. Medication noncompliance is very common and very problematic, and our current systems of care don't allow us to accurately determine when a patient has obtained their medication, let alone taken their medication. There are dietary issues that have an impact on readmissions and the heart failure syndrome. Although we provide education about the importance of salt restriction, sodium restriction, many patients either don't understand the instruction, don't change their dietary pattern, or they're not in charge of their diet. Other people are. And all these factors at play contribute, perhaps, to these high 30-day readmission rates. The social support of patients may also play an important role. Who does a patient go to when they have a concern? Immediate family members by telephone, friends perhaps, and then of course they have the resource of their physicians to call as well. But in each of these scenarios, the peripheral support and social support system of the patient may not have the wisdom to advise the patient properly. And the common response is, go back to the emergency room. And that phenomenon contributes to readmission rates. All these variables that we're talking about that contribute or perhaps are associated with readmissions have been studied carefully and used to create score systems that predict who's at risk for readmissions. One such score, published by Dr. Grumholz, was applied to patients who are older than 65 years of age and has some power in predicting readmission rates. The overall accuracy rate of the score is not perfect, but it is a standardized, quantitative, and validated score that can be used to predict readmissions. The problem with these scores is they're not perfect, and they don't all take into account some of the social variables that govern readmission rates. Another interesting observation, a very important one, is that once a patient is directed back to the emergency room for whatever the reason, soon after discharge with heart failure, almost all these patients are readmitted. This was an observational study from 2006 and 2010 among approximately 1 million patients who went to an ER because of heart failure syndrome. Almost all the patients are admitted. And so the ER physician's options for managing patients who are representing currently are limited. Often there's a concern that the heart failure syndrome has not been effectively treated. They contact their local hospitalist or cardiologist and the patient is readmitted. That's an important driver. It would be nice to create an option for the ED team to say, yes, I'm concerned, yes, you have heart failure, but perhaps we can manage this problem at home instead of in the hospital. When the decision is made to readmit, for whatever the reasons, the cost of that readmission is very important to appreciate. It's very high. And as a consequence of this excessive cost and the perception that it's all happening because physicians didn't do a good job in the first place, physicians and hospital systems are now being penalized for readmissions. This was a publication from the Kaiser Family Foundation analyzing the CMS rules about payment and readmissions. And they summarized that among the studied hospitals, a very high percent were penalized for these readmissions. Millions of dollars were being lost to the hospital systems as a result of these penalties. So this is not just a clinical problem for the patient and the family and the doctors. It's a costly problem. And so that the value of efforts to prevent readmissions is extremely high. Let's think about the various efforts that have been made over the past 20 years or so to try to prevent readmissions. This was an analysis by the Agency for Healthcare Research and Quality reviewing 47 randomized clinical research trials designed to reduce readmissions between 1990 and 2013. And what was very impressive about this review is that of the 47 trials, only one showed benefit in reducing readmissions. And what were the attributes of this process? It was high-intensity home visiting program. And the key words there, home visiting, means someone went to the home. And the evaluation at the home was described as being high intensity. Programs that were using phone calls and telemedicine were not effective. This is a second review by the Cochrane Group, completely independent, published in 2015. They also reviewed randomized controlled trials of various efforts to reduce readmissions. And they found the same findings. Telephone support, even telemonitoring, did not reduce readmissions within the short time after discharge. This is a frustrating observation and not intuitive. So this prompted me to actually review some of the clinical trials on telemedicine. Telemedicine, as you know, is a method that allows monitoring of vital signs such as blood pressure, heart rate, patient's weight, maybe their heart rhythm, maybe their pulse oximetry assessment of their oxygen saturations. All those variables are sent through electronic systems to a monitoring station. And then in response to that information, typically a skilled nurse reviews the data, shares it with a medical provider, recontacts the patient by telephone to guide them about changing their care. There have been 5 somewhat recent trials using this telemedicine process. Most of them showed not even a hint of benefit in terms of readmission rates. Patients liked it, doctors liked it, and there was some hint that maybe it reduced mortality for some patients, but readmission rates were not changed. Now, the most recent of these telemedicine publications was the BEAT heart failure trial, and I'll just give you a quick summary of this one particular trial. It was large. It enrolled 1,400 patients that had heart failure to either remote monitoring, that's the telemonitoring process, with telephone nurse coaching relative to a usual process of care in which there was no telemonitoring. The intervention group that received the telemonitoring also were given education and the equipment for the telemonitoring. They also received 9 health coaching telephone calls over 6 months, and the nurses called the patients periodically based on the telemonitoring data. Important to note that there was no home visits as part of this program. What did the investigators observe? Among the patients randomized to the telemedicine process compared to usual care, there was no difference in the 30-day or the 180-day readmission rates. There was no difference in mortality within that time frame. Quality of life scores were higher in the intervention group, meaning that the patients felt that they liked the process, they had a better sense of their vitality and sense of well-being at home, but it did not alter this critical variable of readmissions. Very frustrating to learn that, because this is a common method used in our own hospital and around the country in the hopes of preventing readmissions. There are programs that do work. So I mentioned earlier about the value of a home visit. This is a summary of publications in which home visits alone or home visits in combination with hemodynamic data from implanted electronic devices was of value in reducing readmissions. The key elements of this type of program included the home visit. The implanted devices are very valuable, but they're not available to most patients. This is one example of an implanted device, a CardioMEMS device that's implanted in the pulmonary artery. It measures the pulmonary artery pressure, and it sends information electronically to a monitoring station. And that allows the monitoring providers to determine if the pulmonary artery pressures are rising, a hemodynamic marker of worsening heart failure. It allows an opportunity to perform an intervention at home in the hopes of preventing deterioration and decompensated heart failure with worsening symptoms and to reduce readmissions. And it does work. It's a very significant tool, but it's not available to most patients. We also have implanted pacemaker systems and ICD devices that allow monitoring for the level of water in the heart and the lungs. This measurement is also transmitted electronically and used to guide interventions at home in the hopes of preventing decompensated heart failure and the hospitalizations that result. Despite all these methods, hospitalizations and rehospitalizations in patients with chronic heart failure remain high. In 2013, the American College of Cardiology, the American Heart Association, published guidelines to help providers and health systems create programs to minimize readmissions. This is from their publication, the so-called Class 1, meaning everyone agrees that it's valuable. But the level of evidence for the recommendation is level of evidence B, meaning there's minimal research or science to prove that it's helpful. If you just reading from the guideline statement, they advised a multidisciplinary heart failure disease management program for patients at high risk for hospital readmission, and to help implement guideline-directed medical therapy, and to address the various behaviors to behavioral change that are required to prevent readmissions. It's an interesting recommendation, but if we ask, well, does it work, or what systems are in place to help make it work, unfortunately, we still are seeing failures, in a sense, with no real change in readmission rates. This is a summary of our own network's programs. It includes efforts prior to discharge and after discharge by nurse specialists who sit with the patient in the hospital to provide education and counseling. We have a large community care team that make phone calls. We have heart failure clinics supervised by nurse practitioners who are skilled in the management of heart failure. And of course, our ED programs around the community. All of these are resources to patients, in addition to their primary doctors and cardiologists, to assist with their heart failure management. And we have visiting nurse programs as well. Despite all these programs, our 30-day readmission rates in the past year are still 20 to 23% range. This prompted me to say, we need some new strategies. And this is what led to the concept of paramedicine as a potential resource to change this pattern. There have been various publications and editorials about the value of paramedicine in the community. Chris Greb shared some of this information with you. But there's a lot of support for the concept that you as a paramedic can make an important impact on the readmission process. This is a cartoon from the advisory board published in 2015. The advisory board is a national consulting group that studies processes of care and hospital systems around the country to identify systems and processes that are valuable, systems that reduce the cost of care and improve patient outcomes. And I think that this cartoon is very applicable to our discussion today. Notice the title, Make Your Patients Healthy and Your ED Happy with Community Paramedicine. How or why did they come to that proposal? What they did was studied programs around the country, here's a sampling of them, that use paramedics in an effective way. So, for example, the MedStar Mobile Healthcare Program, they used community paramedics to do home visits within 30 to 60 days after discharge. And they observed that this program saved the hospital system $2.5 million. They reduced readmissions. They reduced ED visits. It was a very successful observational study. The New Hanover Regional Medical Center also created a program for community paramedics in which they arranged for home visits for up to 6 weeks among the high-risk patients who had chronic disease, not just heart failure, but other forms of chronic disease as well. And they observed a significant reduction in 30-day readmissions. All of this lends support to the basic hypothesis that we've created, that house calls by paramedics can make a difference. Specifically, our hypothesis is stated here on the slide. Compared to standard care in our usual process, house calls by mobile integrated health paramedics will reduce 30-day readmissions for heart failure and improve our patients' perception of their care. We also created a secondary hypothesis that compared to standard care, house calls by paramedics will reduce all-cause readmissions within 30 days of discharge, meaning not just hospitalizations related to the heart failure process itself, but rehospitalizations for other issues as well. To test this hypothesis, we proposed a research trial in which patients would be randomized to receive usual care, or by the flip of a coin, additional care by paramedics with house calls. But before implementing such a research trial, which is a major effort with certain costs, we wanted to determine in our own community, is this feasible? So we created a pilot study to test the feasibility of this idea. We wanted to be able to identify 20 patients with heart failure willing to accept a home visit by a paramedic 2 days and 15 days after discharge. We wanted to be able to create a process that would allow for an urgent, unplanned house call by paramedics anytime from discharge to the first 30 days. And ideally, we would identify a person who could help us analyze the economic value of this process. With the help of Chris Greb and Orlando Rivera and other individuals, we designed a detailed research protocol to test the feasibility of this idea. We've had lots of support from individuals listed on the slide. Debbie Salas-Lopez, who you heard from earlier today, Kay Werhan, who you heard as well from the Population Health Program, We've had biostatistical help from Hope Kincaid in the NORI group. They're the network of research and innovation at Lehigh Valley Hospital. And we've had important support from our ER team. Dr. Marna Greenberg and other selected command physicians are participating and supporting the program. And of course, we have our nurse practitioners who are the Marines. They're the people who currently take care of these patients in the hospital and in the office. Alma Ohl, who you'll meet, Denise McPherson, who's an important nurse educator in our hospital system. All of these individuals and others have been very supportive of the program. This is a list of the command physicians, each one experienced and knowledgeable about the process of care for heart failure patients and the problem of readmissions. Each one of them understand the need to reduce readmissions. And of course, we have you, our paramedics, who have agreed to participate in this program to acquire additional skills beyond what you have already. And we believe that you will be able to help us a great deal. To summarize, new strategies are needed to reduce 30-day readmissions. Community paramedics working within a mobile, integrated health paramedic program have that capability of providing a timely response to patient concerns, and guided by medical providers, the ability to provide acute medical interventions in the home if needed. We believe that a timely response to patients' reports of any medical concern, including concerns about new or worsening symptoms of heart failure, will reduce ER evaluations, reduce hospital readmissions, reduce cost of care, and improve their own perception about their care. Thank you very much for participating in the program. I will serve as a resource to help you and help us all be successful. Thank you.